Well, actually, thank you for having me here this morning. And this talk, I have 15 minutes to discuss sports participation in total knee arthroplasty. Well, the Knee Society has issued recommendations regarding the return to activity after total knee arthroplasty, and it advises patients to avoid activities that stress the implant. That seems reasonable. They encourage activities such as bowling, doubles tennis, swimming, low-resistance rowing, walking, hiking, and low-resistance weightlifting. They also discourage activities such as hockey, which a lot of my patients play, soccer, or football, I should say, down here, jogging, rock climbing, and parachuting. And I actually had a 76-year-old woman who decided that she wanted to go parachuting. You never know. However, this advice is based on expert opinion and surveying total joint surgeons in the United States. It's not scientifically confirmed. Because patients returning to high-impact sports after knee and hip replacement is a true reality for us as orthopedic surgeons, Mayo Clinic had recently performed a study to determine the effect of high-impact sports after total joint arthroplasty. What they found was the difference between patients who participated in high and low impact sports activities. There was really no difference in radiologic findings, and the revision rate for mechanical failure was lower actually in those that participated in high impact sports, 8.5 versus 11%. This was not statistically significant. There remained no difference in failure rate between these two groups. Also, there have been other studies that indicated that the high-impact sports participants actually did better in their functional outcomes than those not. So where do we go with that? However, that's basically sports participation after total knee arthroplasty. So I'm done. Well, I have 12 and a half minutes left. So what I would like to discuss now is something I spoke about yesterday. I want to do it in an abbreviated form of a presentation I did over on the other side, because we have to understand how we can get our patients to that point where they can participate in low or high impact activities. We need to focus on the individual. Not necessarily the surgical procedure, not necessarily the surgical implant, but the individual themselves to get them ready for their activities, whether it's just walking or playing soccer. The focus of this presentation is the how and why. We believe that getting patients home sooner is better for them. It decreases their incidence of complications and improves their outcomes. And it's also better for us as orthopedic surgeons and better for the hospital. It's improved patient satisfaction and cost effectiveness. Over the last 25 years of doing this, I've seen my length of stay, the stay in the hospital change from 11.5 days in 1985 to 1.18 days in the hospital last year. The vast majority of our patients, both primary and revision total joints, go home the next day. That goes home. That is not to an extended rehabilitation facility. It's not to a nursing facility. It's home. There's mounting evidence that suggests there is no single factor that alters or predicts the amount of pain relief of function after total joint arthroplasty. Young, in this 1998 article, was trying to determine what patient would have the best functional outcome. That was a patient who was between the ages of 45 and 75, who weighed less than 70 kilos, who had strong social support, had a higher educational level, had better preoperative functional status, and had no comorbid disease. Now that patient is the ideal patient. However, we don't find that, so we need to try to get more of our patients in line with that prior to surgery and manage them better perioperatively. Now, the surgeon-directed factors that we deal with, the type of implant. In the knee, you can talk about rotating platform versus fixed bearing. You can talk about cruciate retaining versus posterior stabilized. Surgical technique, we often hear about the MIS approach to the knee or the anterior approach to the hip. Navigation is popular in the United States and around the world, and also custom cutting blocks. But of these, the only one that really has been shown to make a difference is the last one, and that's the perioperative protocols. Now, the patient-related factors, I think, are the more important. It's these that I think will alter the patient's outcome more than almost anything else we do. And it's one that we probably haven't done as good a job with. These are patient expectations, nutritional status, preoperative functional status, psychosocial status, and preoperative pain level. Expectations, interestingly enough, if patients have expectations of a quicker recovery, they often do so. At least they perceive so. So the patients feel they will do better and are prepared to do better, they often do so. Better nutrition has been shown in many studies to improve outcomes after hip fracture surgery and a total joint arthroplasty. Preoperative function was a significant predictor of long-term outcome after total knee arthroplasty. So the better the rehabilitation of the patient prior to surgery, the better the patient is preoperatively in functional status, the better they can do in long term. Also, poor emotional health seems to lead to smaller improvements. So we need to do better in improving that prior to surgery. Psychosocial variables are significantly related to total knee replacement's functional outcome, especially motivation. The more motivated they are, the better they do. Also, depression and anxiety is associated with heightened pain 1 year after surgery. So we need to do better understanding, screening, evaluating, and treating. Preoperative pain, Brander and David Stolberg up in Chicago found that patients who have greater preoperative pain have more postoperative pain. That seems reasonable. They also require more postoperative manipulations. So we came up with a comprehensive protocol. It was designed to help facilitate quicker recovery, shorter length of stay by limiting complications perioperatively. We focused on the medical and psychological management of patients and improved communication with them. It was designed simply so as to be implemented anywhere. Extensive preoperative education, consistency, and expectations. That's what we had to deal with. Also, pain control. We believe in stacked modalities. Blood management, early mobilization, and implementing a nutritional program. Anesthesia, we generally use general at this point. Spinals was something we had given up just recently because the surgeries are so short, but you must have good nausea control. We discharge them home the next day if they're medically stable and physical therapy gives their okay. They walk 100+ feet, get out of bed independently, do steps, and so they go home. The length of stay in our results was significantly shortened. The time to work and time to driving and actually time to sports participation, which is actually the topic of this talk, was shortened. The use of ambulatory assistive devices was lessened, and patients were more satisfied. How was this done, you might ask? The complete recovery program, as we call it, begins in the office in preparation for surgery. Education assists the patient in having clear expectations of the recovery process and the knowledge to implement a home regimen to achieve the desired outcomes. Very important. We look at telephone support and involving family members. We look at consistent expectations. Hospitals, we feel, are for sick people, not for patients having total joint arthroplasty. And we also believe that 70% of the patient's outcome is up to the patient, whether genetically or motivation-wise or expectations. and only 30% up to the judgment of the surgeon. We stop their anticoagulants prior to surgery. We consider IVC filters if they have a significant history of VTEs. We're trying to eliminate the perioperative complication. We discuss pain management and what the patient should expect. We try to deal with the catastrophic thinking, which is a predictor of pain after surgery. In the OR, we try to keep our surgical times short, less than 1 hour. We handle the soft tissues appropriately and do a good job, if we can, of balancing the ligaments. Because the more balanced, the more normal feel that the patient has, the better they do, and the more active they can be in sports. Recovery room, we try not to over-sedate them. We address their nausea issues, and we start pain management at that time. We came up with what's called a theory of 6-hour windows. It's very important to have patients feel they're progressing, and we actually progress them pretty quickly. Each 6 hours, they have something after surgery, something that they need to accomplish. In the operating room, we try to keep the cases short. In the recovery room, we don't over-sedate. On the floor, once they get to their room, we get them up vertical with physical therapy. We try to mobilize them. Overnight, we try to let them rest. The next morning, we give them freedom from all the things that attach them to the hospital bed: IVs, PCA pumps, Foley catheters, drains. And then later that morning, another window. We get them, to change the dressing, get them up moving, and then if they do well, they go home. And that's right now, with total knee arthroplasty, about 95% of our patients. We use stacked modalities for pain: IV Dilaudid, Toradol, Tramadol, Celebrex, Tylenol, hydrocodone, oxycodone. We don't use femoral sciatic nerve blocks, because we feel that prevents them from getting up early after surgery, and there are evidence that increases complications. We do prophylactic doses of Decadron, Reglan, maybe scopolamine, Zofran, and Pepcid to prevent nausea. We're very aggressive at preventing VTEs, blood clots, early mobilizations, intermittent pneumatic compression devices, TED stockings, and we risk stratify, sending our low to moderate risk patients home on aspirin, high risk on enoxaparin, and everybody gets enoxaparin in the hospital. We break it down to a first 4 weeks, where is what we call the recovery period. We actually give the patient a chance to recover slowly. Once we get past that, we really get more aggressive in the rehabilitation stage. We remind the patient, and remind ourselves actually, that the first 4 months, first 3 to 4 months, is what it takes to heal. If you look at the biology of healing of soft tissues and bone, if you look at the physiology of recovering and regaining stamina, it is 4 months. So no matter how good we are with surgical techniques to get our patients up and moving quickly, it still takes that amount of time for the patient to feel more normal. And if they don't expect that, they're going to be disappointed. Patients' perceptions are very important to understand. We try to individualize and understand each patient. Hips tend to recover easily after surgery, and they just move on. We don't see them very much. Knees are more difficult. 10% are generally unhappy, 60% are better and satisfied, and 30% seem to be extremely pleased. During the recovery period, it's really important to stay on target during this period. We feel it's important to empower the patient, the individual patient, to take ownership of their own recovery. The more they're involved, the more they take ownership of their rehabilitation, their recovery, the better off they are. While we need to continue to evaluate surgeon and industry-directed factors, such as new implants, MIS technique, navigation, clinical protocols, understanding and assessing other patient factors which could influence the outcome should also be considered essential. Improved management of expectations, nutritional support, depression, anxiety, preoperative pain and function, and sleep apnea, and improved communication may be even more influential in determining implant performance, and patients' ultimate outcomes. Therefore, we definitely need more research on these patient factors, better initial screening of surgical candidates, while having more discussions like these to reach a level of understanding how to influence the design and development of the next generation of implants and treatment pathways in this highly complex field. Thank you.